that's difficult. That's the only thing.
Yeah.
Shall we wait or shall we start? Sandil has joined. And Saqib. Welcome, Sandil. Saqib is on.
Saqib is on call, isn't it?
Yeah.
He's writing something. Yeah.
Can everyone mute themselves, those who are? All right, he's joined. Well, Sandil, do you want to keep the timer?
Yeah, sure. 15 minutes, right?
Yeah, 15 minutes, Sandil. Or shall I start?
We'll start with the incisional hernia study.
Yeah, I have chosen the incisional study. Incisional
Okay.
hernia study.
Okay.
Okay, I'm going to.
So before that, basically, this is you in the exams you may be given papers which are more, which maybe sometimes more like to your specialty, but I've genuinely these are mostly general surgical ones. So you can't say in the exam that this is not your specialty. So that's why this is kind of more generally oriented.
Yeah.
Yeah.
It's okay. Shall I start?
Yes, please. Thanks.
Okay. Actually, this paper is from British Journal of Surgery, which was published in 2022 edition 1 to 7. And the topic of this study is the effects of short stitch technique for midline abdominal closure on incisional hernia. This is a randomized control study. There were plenty of participants. It is a multicentric study which has happened in 7 hospitals in Germany and 2 hospitals in Austria. The primary author is René H. Fortenelli. He belongs to Austria, and the impact factor for this British Journal of Surgery is as more than 6. It has got high impact factor, and this overall this looks like a valid study. However, there are few uh, uh, things which has to be considered, which I'll let you know at the end of the discussion. Regarding the abstract, the background of the aim of this study is to compare the short stitch versus the long stitch in a incisional hernia repair following a midline laparotomy. The method which they have followed is the design for the study is it's a randomized control study and it is a double blinded. So the effects of the procedure has not been um, is not revealed to the surgeon, but the surgeon is not blinded. and it is a multi-centric study. It has happened in different hospitals in different countries, and a parallel group study. There was no crossover of participants in between the two cohorts. It's a prospective study, so the effects of the causal effects has been followed up and picked up. The most important thing is uh, uh, um, regarding the endpoint, the primary endpoint which they have aimed is recurrence of incisional hernia, which has been clinically and also image-wise picked up. Sorry, Amar, have you left?
You're audible.
No, Amar was coming back. He left and he came back.
Yeah.
Got it.
Sorry,
Okay.
Amar, where did you miss?
Sorry, can you come start from the
Yeah.
starting? Sorry, just BJS.
All right. Okay. Sorry.
That's fine.
Okay. This is we'll restart again.
Yeah.
This
No,
is
no,
a
you
study.
carry on.
So regarding the abstract gives a short, crisp about this study, and they have. It's a multicentric study which has happened in 9 centers across Germany and Austria, and there were 9 hospitals which has participated, and it is a randomized control study and double-blinded study. It's double-blinded. The people, those who analyzed the study, were not aware of who is the participant, which group is the participant is, and it's a parallel group study where there is no crossover of participants in different groups. The method which they have followed is two groups has been allocated, one with a short stitch and one with a long stitch for the incisional hernia repair. In the short stitch group, the stitches has been taken every 5 to 8 mm, with 5 mm from the edges of the scar or the defect, and they have used 20 thickness material, which is Monomax is a brand name. The generic name is poly 4 hydroxybutyrate base suture material, and the suture, the needle size is 26 mm. In the long stitch technique, they have used 10 mm stitches every 10 mm stitch. The distance between the two stitches are 10 mm, and the distance between the edge of the defect and the bite is 10 mm, using one thickness material, and it is a double loop, and the thickness of the needle they have used is 48 mm. So they have compared these two groups, and the results has been analyzed. They have found a significant. The follow-up is the main primary aim of the study is to check for the recurrence at 1 year, and they have planned it for third year and fifth year, which has not been revealed in this study. So this study shows the results at 1 year, and so coming on in detail regarding the introduction to this study, they have incisional hernia is a common thing after any midnight laparotomy, and this looks like a follow-up, an extension of the stitch trial, which also included the same principle, like uh, short stitches have a good outcome than the long stitches. However, this stitch style does not include didn't include any incisional hernia. This is an extension of probably an extension of stitch trial. Describing the methods of the trial, this trial has been registered in clinical trial on October 2013, and it has been approved by the local ethical committee. Uh, Local ethical committee. The inclusion criteria for this study is all the adults have been included who had a midline laparotomy, primary midline laparotomy, and ASA of grade 1 to 3, and the midline laparotomy incision should be more than 15 centimeter for the participants, and this expected survival should be greater than 1 year. They have excluded the people with BMI of 30 and pancreatic tumors, and the patient who had laparotomy for abdominal aneurysm, and who had conditions like peritonitis, coagulopathy, immunosuppressive, who had immunosuppressive therapies like steroids and azathioprine. They excluded pregnant women. However, they made us two relevant changes during the study. One is the participants, those who had BMI, exclusion criteria of greater than BMI 30 was decreased to 25. Considering this, considering the people between 25 and 30 are also more prone for this recurrent incisional hernia, and also they changed the terminology of pancreatic tumor to pancreatic uh, carcinoma, because they can include people those who have benign tumors. And the most important intervention, as I said, they compared two groups. The methods is one group had long stitch in the sense 10 mm between the two intervals, 10 mm from the edge, from the defect margin, and they have used 150 centimeter loop
No, you have told that.
monomax.
You have told all. You have already spoken about that. Yeah, go to the outcomes then.
Okay. Regarding the outcome, in the primary outcome, they have followed up after a month. In the primary outcome, with the short stitch, they have found um, okay. The primary outcome, they analyze the primary outcome either clinically or using images, either CT or MRI, to look for any recurrence. And the secondary outcome, what they have analyzed is the
Was
quality
it
of.
was it was it was it or CT? Was it one radiological imaging? Isn't it?
Yeah,
It
either
was
CT or
clinical.
ultrasound or MRI.
It was ultrasound, and
Ultrasound
ultrasound
was,
was substituted with CT or MRI if the patient had, say, a tumor or something else. So it
yeah,
was clinical exam plus some radiological examination.
yeah.
Oh.
So secondary outcomes which they have analyzed is quality of life and
Mm.
short-term complications like surgical site infection, healing disorders like seroma, hematoma, and other events which are directly related to wound healing. Also, the length of hospital stay. These are the secondary outcomes. And the most important thing is burst abdomen and incision hernia, which they have also analyzed. Regarding the sample size calculation, they have used the previous study to calculate the sample size. So the ISAC study has been calculated. In the ISAC study, the risk of developing incisional hernia has been analyzed as 19%, and the relative risk reduction using the SARS technique is 16% in that study. Using that thing, they have calculated the sample size in this study, considering 1 year incisional hernia rate in 50% of both the groups, including 9.5% in one group and the other in other group 9.4% in the other group. They've calculated the sample size to be like 424. They have considered the dropout rates as 10%. So the sample size calculation has been perfectly done, with including the dropout rates, including the risk, including the chances of incision hernia in both the groups. Also, they have done an interim analysis uh, because they thought that uh, though they have calculated the sample size, they thought that the uh, number of incision hernia happening during the course of the study is less compared to what they have expected. But however, they have not stopped doing anything. They just uh, continue with the study without any changes in the study. Regarding the randomization, they have randomized perfectly. They have used the computer software called as SAS 9.1 software to randomize the population, randomize the study group, and also they have concealed they have done an allocation concealment using a sealed suture material. They have used the suture material to seal it, and the surgeon was said about the procedure. However, they have done a stratified randomization, as this is a multicentric study. The stratification and randomization has been done centrally, and the surgeons were given the concealed suture material. Regarding blinding, the surgeons were not blinded. However, the person who analyzed the uh, uh, effects of the procedure has been blinded. And so regarding the statistical analysis, the follow-up, they have followed up for 1 year, and they are planning to follow up in third year and fifth year, which has not been published here. The software used for the statistical analysis is again SAS software, which I'm not aware of. I've used only SPSS software, and the confidence interval they have used is 95% confidence interval, and they have used chi-square test to compare the rates, and the p-values, the significant p-value has been assigned as less than 0.05. They have considered BMI of 30. The patient, those who have BMI of greater than 30, they have used logistic regression model to consider.
2 minutes left.
So regarding the patient's outcomes, results and outcomes, they have used the concert material to concert pro forma to go ahead with the analysis of the RCT. They have compared the short stitch. In the short stitch, they could say the number of stitches are more than the more in the short stitch than the long stitch, and comparing the suture length. The suture length is more in the short stitch than the long stitch. The overall quality of life is more in the short stitch than the long stitch, which has been used using the EQ5D questionnaires. They included anxiety, mobility, self-care, pain, and activity to check the quality of life, and it was found that short stitch has got good quality of life than the long stitch. Also, there were there were
for only pain and self-care. Only two things short stitch was better, but there was no difference for other things. All right.
Okay, and regarding the recurrence rates, there were 7 recurrences in short stitch and long recurrences in short stitch. Overall, I feel like we have to wait for the other 3-year and 5-year follow-up results to check for the hernial recurrences. However, what I feel is like the material which they have used, Monomax, looks like has got more
That's fine.
more significance in using the Monomax. All right.
Sure. So this is like a paper where the examiner just keeps quiet and allows you to present, which is quite rare because sometimes the examiners, they kind of ask you questions in between. But this is like if you go in the mornings, it will usually be the case where they give you, they allow you to present. But as you go towards the afternoon and the evenings, mostly they have the same papers and they're bored. So they start asking questions first up. So you can have questions which are starting, they start with the questions, or they can allow you to present. But if they allow you to present, you get into a flow and you can explain it better. Actually, it was quite good. You explained about about how the study was carried out, about the abstract, the introduction, gave a little, an introduction about what BJS is about and things like that. Sometimes they would also ask you about basic questions like what is an impact factor, things
So
like what is an factor?
Impact factor is for a particular year, they have to calculate number of citations in the previous 2 years divided by number of total articles from that 2 years.
Mhm. So which is the we name some articles which have the highest impact factor. So questions like that they can ask you.
Mm.
But the highest impact factors, and what is the importance of an impact factor?
Impact factor, it gives you more about the number of valid articles which can give good results, which can be used in the regular practice.
Okay. How important is the validity of an impact factor? You're calculating the impact factor. Is it how do you think is it how important do you think is it validity?
In the regular practice, impact factor gives it makes us to implement those principles of the articles in the regular practice. Sometimes there can be a publication bias with high impact factor.
Okay. And what are the impact factors? Basically discipline dependent, isn't it? Like for some articles, some journals which are like for cancer journals which are very rare, the impact factor will be quite high. For some other journals, the impact factors will be quite low. And hello.
Yes,
we can hear you.
Yeah. So another disadvantage of impact factor is it does not follow. It follows. The thing is, it is calculated. It is sometimes it is calculated. It does not correlate with the journal rankings on expert surveys. So this is one disadvantage of an impact factor. And as you said, it has got editorial policy bias and publication biases which may affect it. Okay, coming back to this study, can you tell? You presented very well about the methodology that they started, and you explained about the computer generated sequences and other things. So what do you think about the when you go, if you go through the thing, have you ever used Monomax first of all?
Never used Monomax.
So what is their, yeah, so what do you think is the rationale that they have used this suture above other sutures?
So they compared the Monomax with the PDS. In the PDS, the elasticity is comparatively low, and also the absorption rate is rapid.
Yeah. No. Why did they use Monomax in the first place?
Is it because of the study Stitch trial which has used the Monomax?
No. Stitch trial did not use this. This is a trial which is based only on this hydroxybutyrate suture, this Monomax suture, where they're using Monomax for both short stitch as well as long stitch.
Yeah.
So they are using this because it has got better viscoelastic. It is more elastic, and they say it has got better tensile strength. Yeah. So the risks of burst abdomen are not there. So that is the reason, isn't it? So that is the reason that they're using. Yeah. So when you go through the criteria, inclusion criteria, are you what do you think about the inclusion and exclusion criteria? Do you think that they've selected good ones, or what do you think about the criteria?
Yeah, I think they have excluded the exclusion criteria is perfect because they have excluded the patient those who are on steroids, which can impact the healing rate and which can cause the high recurrence, and also they have excluded the patient those who are on isothioprin, which again causes a decreased healing rate. Yeah. And regarding the BMI, yes, increased BMI has got decreased facial strength, and these people have been excluded. So definitely they have chosen the people, excluded the people with a perfect the criteria which can impact the study. And regarding the inclusion criteria, not sure why they chose only the people with greater than 15 centimeter.
I think that is for some homogeneity. They wanted to, because it is a multi-centric trial, they wanted to have it at many places. They wanted to have a long enough wound not a very small wound in the sense,
Mm.
so that they selected an arbitrary length of around 15 centimeters, so that it gives them a criteria in which to work on.
Criteria.
Yeah,
And the second thing is they have
because you
included.
can't compare a 3 centimeter skin incision with the, say, a 15 or 20 centimeters, isn't it?
Okay.
So
And
you need
also,
some criteria to stop for that.
yeah, they've included grade ASA 1 to 3. That is fantastic, because any people with 4 or 5 is more prone for morbidity and mortality. And also they have included survival criteria of longer than 1 year,
So they
which
have,
also includes
yeah. So they've included basically fitter people, isn't it? More
fitter
fitter
people. Yeah,
people, people going for surgery. They've excluded all people with
emergencies.
cancers, cachexias, abdominal aortic aneurysm, which is known to produce more incisional hernias
Yeah.
with surgeries and things like that, corticosteroids, chemotherapy, and everything. Okay. So, so how would you on going to, what is your thoughts on the randomization?
This is a multi-centric trial, and they have randomized using computer software. This has been stratified. Stratified randomization has been done. Um, they've made a separate list, randomization list, and to avoid center-specific effects, it's a stratified used. I'm not sure exactly what exactly, but they have used uh, computer software to randomize, and they have concealed the suture material for that particular patient, and they have given the suture material to the surgeon, revealing what exactly the procedure has to be done for that particular patient. Looks like.
So what are the steps that they've taken for helping in homogeneity? So they've taken a lot of steps, isn't it? So what are the steps that you see that they've taken to maintain homogeneity? Because they've done it in over 100 centers.
Yeah, they prepared a randomization list using a software.
For homogeneity, in the sense, they have, how did they make sure that all of them were following, all the centers were following similar ways of doing things? One is they have given them a video, isn't it? So to make sure that they follow the, you know, the how many suture lengths you have to take, how many throws you have to make, and things like that,
Yeah,
isn't it?
yeah. They have like the nurses have been informed about the number of throws they used
Taught
to
how to
do,
count.
and all those things. Yeah.
Yeah. So in the outcomes, so crisply, what does the outcomes say? The outcomes say that the short bites have got. So can
Lesser
you tell me
chances
what?
of incidence. The outcome says there is a lesser chance of incisional hernia in patients those who have short stitch. It includes 3.3% out of 7 out of 210 patients, and also 13 out of 204 patients, which is 6.4%. However, with including the dropouts, they have used per protocol analysis to confirm these results, including the dropouts. Even then, they have found like 7 out of 165 patients with the short stitch, and 13 out of 158 patients in the long stitch had incisional hernia clinically and radiologically.
So
So there is
basically,
definitely a.
yeah. So basically, they say that short stitch produces lesser hernia rates.
Yeah.
However, the overall surgical implications is that surgery for both was quite the same. So
Same. Yeah.
probably more short stitch ones went for surgery because they were quite serious in nature, quite larger and
Mm.
quite serious in nature, whereas the normal ones produce more hernia rates, but they were not serious, so probably they didn't go for
Yeah.
more surgeries, isn't it?
Yeah.
What do you mean by intensity to treat? You said intensity to
Intention to treat
intention to treat.
intention to treat is all the patients those who are included in the study has to complete the study, including the follow-up, and uh, if there is any dropout, then it leads on to the attrition bias. So this
There
is
is no
called
crossover, yeah. So basically,
Yeah.
there is no crossover in a intention to treat study, isn't it? There is no
Yeah.
crossover, and you just follow till the end.
Till the end of the primary outcome is analyzed.
Okay. So what are the limitations of the study that you think?
So there have been a good limitation about this study. One is the unexpected low number during the study, and they thought that there is a
Why
high
did
number of
they? Yeah. Why did
high
they
number of
think there is a low number of incisional hernias? Why were the
they,
number of incisional hernias lower than what they thought?
they think that it could be because of high laparoscopic procedure compared to the open procedures and high number of participating surgeons. These are the two things which they think that could be the reason for the low number of incisional hernias. However, they have continued with this study in spite of that, in spite of this limitation. And also the re-laparotomy, the people, those who have not included re-laparotomies, they have not included re-laparotomies. So this is
So
also another
reason why they think.
limitations.
Yeah. So would what do you generally think of this paper? What is your opinion of this paper?
This is a good initial study to start up with. These results can be considered in the mind, but I will wait for the 3-year and 5-year results. But at present, I feel like the suture material which they have used is a reliable suture material to start up with in my practice, which has got good elasticity, good absorption, so longer longer absorption rates compared to the PDS. So I will try to use the suture material, which looks like better. However, regarding the results, I'll still wait for the further input on the 3-year and 5th-year follow-up. Can be used for the particular patients with the good fit and reality patients.
So, what is there any conflict of interest in this paper?
Authors declare no conflict of interest. However, I feel like there is a sponsor. This is funded by the a company, Brown company, which provides the suture material, but there's no conflict of interest from the author's side.
Okay. So there is no conflict. They declared whatever conflict of interest that they have declared actually. Some of them have been working for Bard and other companies also. So they've declared whatever they have. Other than that, they have no conflict of interest. Some of them have a little, but they've declared it. So that is one of them.
Oh, okay.
All right. Would you publish this paper if you were the editor of a journal, and why?
Yeah, this is a good initial study. I would like to publish it because it's a well designed randomized control study, prospective study, and they've included all the positives and negatives in this study, and they are still working on the further follow up. Yes, it is good to publish this article.
Would you have waited till the end of the 3 years to publish, or would you have published at 1 year itself? Because they themselves say that at the end of 3 years, there will be a large, more hernias occur only later. So what is the rationale of publishing it at 1 year? Do you think that it could have waited for some more time?
With the initial results, they could definitely give a initial initial difference in the start stitch and long stitch in this particular cohort of people. So still it's worthwhile to publish, but it has to be republished. We have to check the 3rd and 4th year follow-up studies as well. It's good to publish right now because of good has an added added effects in this.
Okay. Do we still have time, or is it like
Done?
No. The time was 15 minutes. Ended when long back.
No. Okay. We'll stop with this, shall we? Because we have one more.
Yeah. I stopped it at. It was 15 minutes when you actually started the discussion.
We'll stop with that. So
And
mainly
the outcomes, it was 15.
Okay, sorry. So we'll stop with this. My thing is that keep practicing more and more. It is these are the basic questions that an examiner will ask. Examiner who doesn't go into statistics. Most of the surgical examiners don't go into statistics. This is what I've seen. do too much of statistics at least. And they mainly concentrate on the discussion aspect of it and things like that, and what you think and how will it affect your practice.
Amar, the most important thing which I felt is like when I started reading this article, it took me like 40 minutes in total to read the article and mark all these things. The second thing is how crisp we have to be. Like I felt like 15
The,
minutes. I was not even
yeah.
off the way down the.
Yeah, the thing is be as crisp as possible. If you can use, they give you color markers in the exam to mark. So you can take 3 color markers. What I advise is have 1 color markers for all the mundane things, like how the study was done, this and that, and have another color like a green or a red. A green is to say all the good points in the study, and have a red for all the bad points in the study, so that whenever they ask you, sometimes how they will is they will start with what are the good things in the study. Okay. In that case, you will be like, this is like a good case scenario where they allow you to speak and go and, have your own way. But mostly when they're tired or in the end of the, program, like when in the end of the day, they tend to be very to the point. It's then that it gets difficult. So you have to prepare for both contingencies. Like one is for, this is the easier way. They allow you to keep going on and on and on and allow you to present, but sometimes they will interject if they feel that you're going off target. But this time I've just left you to just present for the sake of it. Like this is just the first thing. So once you start presenting more and more, it will improve. And if you keep presenting more and more papers to your friends and you prepare, it is even more better because it helps to increase your speed of presentation and get right to the point. But however, I suggest you concentrate on the abstract. The abstract is what they are expecting you to say. The abstract also contains the main essence of the study. So if you say that crisply, that would be the best. And methodology and other things are all, you can expand on that. So if you can start like saying about that, this is a trial about this and this. These are the authors. This is published in BJS, and this is a reputed journal, and this and this and that. And it has an impact factor of this. And what is the basic methodology? So just concentrate on the abstract, the methodology in the abstract, and then go to the results and say the outcomes.
So
and say the conclusions.
In this paper, the abstract doesn't give all the relevant data. What is mentioned in the whole of the paper. The abstract is so short. Like I can say, they've just in the methods. You can see just like what they have compared and what is the overall result in this thing. I don't think it has completely reflected the whole of the paper, isn't it?
Yes, but that's you can. This is in the methodology. Maybe you can add a little, but this is the basic essence of the paper. So first, tell this that you're clear with the. There are 2 ways. One is to go like from the introduction, methods, results, and conclusions. The other is when you say itself, you can say they've compared this and this, and they have found this. The outcomes were 1, 2, 3. This was the outcomes, and then you can go and give a bit of an introduction. So there are 2 ways to do it. One is the way that you do it, like give an introduction, methods, and go slowly and explain. But the point is sometimes some of the examiners get a bit, jumpy and they want to interject. So that times your flow of thought is a bit disturbed. So in that situation, I would suggest start with an introduction, go with what the study says, just the methodology alone, keep it very crisp. Then say they compared this and this, where they found, say the results. That's the basic essence and the conclusion on elaboration. And then you can go and describe the methodology. So this is one way of doing it. This, if they allow you to present it, keeping quiet.
Okay.
All right. So I would suggest that the second option is better in the sense you get instead of going too much into the methodology, because what happens is when you go too much into methodology, we tend to get caught up in the basic, in the minutiae of things, the things that you need not, it's not going to make much of a difference. You may get caught into those things, which may not necessarily, help you. So when you show that you're very crisp and you give the basic methodology and you go for the outcomes, it is much more impressive to the examiner, and it is much more fluent on your part. Because when you go into the methodology, when you go into more and more details in the methodology, you explain more and more. It is sometimes irrelevant. Sometimes, for that at that point of time. B, sometimes we go rambling off the topic. So it is much more. So the examiner sometimes interjects. So it would be better if you can give a very crisp methodology, then go more to the results.
Discussion part.
Yeah, the results. When you present first, give more the results, then give the conclusion, and then you can say on elaborating, and then you can go about the study. Then you have already covered all bases, and then you can go into the methodology in detail, so that you have covered all bases and you give a crisp idea of what you have understood to the examiner.
Okay.
Amar, may I just ask a few specific questions? Just get your opinion on it.
Yeah.
One, I thought just for the sake of critique, the title is not reflective of it being. I mean, you can't see the other arm on the title as the randomization. It says effects of short stitch technique on hernia. It doesn't say short stitch versus long stitch.
Yeah, that only you go in if you find it out. Actually, it does not accurately reflect what they really did. Actually.
Yeah. Okay. That was one. The second thing is what they mentioned about superiority trial. How does that say affect if they ask you, is that a good thing or a bad thing?
Even I felt, what is that superiority trial?
Superiority.
Non-inferiority or superiority. So.
Yeah, it is difficult to prove superiority, isn't it?
Exactly.
It's a non-inferiority, basically, this study. I really don't see it's a superiority study in the first place. So that is also, I don't think it's accurately reflected in what they have said.
Yeah, that's what I thought. And then is it important to mention, ultimately, the result is not of statistical significance? I mean, it's not that it's a bad thing, but...
Yeah, it has got no statistical significance. That's what, but we need larger numbers, isn't it? The numbers were about 90, and there is a lot of heterogeneity involved. So we are not really sure. So it requires, so you can leave, as far as exam purposes, you can always say it requires a larger study to get a clearer view. And it's a new material which has not been used so far. And we need more information before we can come to a conclusion.
And the other thing in terms of heterogeneity was, I think there's 106 surgeons that were involved. So that was a point towards heterogeneity. And what about the use of multiple log regressions? Does it weaken the study because they had to alter it thanks to the inclusion of BMI?
Definitely, so but they went and continued it with the same thing, which I would, which is not like really what you should have done. But anyway, they have just followed it after them.
Okay. And the other thing is about whether, although it's equal in both arms, most of it was colorectal surgeries, about 55% in each arm.
I think it's upper GI. Most of it were upper.
No, most is colorectal. Colorectal and rectal comes to about 55%.
Oh, sorry, colorectal and followed by upper GI. Yeah.
It's followed by upper GI. Yeah. So I don't know whether that changes anything, but
yeah, those could be critics also.
So more concentration on the results and more on the methods and results rather than the methodology and all those things.
Yeah.
And Varun and Amar said, I think as you go through the methods, rather than stating what is, or after stating what is in the paper, just give one comment saying this is good or this is bad, so that as you go, you kind of get it out of the way. They don't have to ask you in the end what is good about it and what is bad.
But the counterpoint is sometimes when you say it is good, they will ask you why, and your flow gets disturbed. So I would rather keep it for the end, because sometimes your flow gets disturbed. If they keep, because the next one we can do as someone where you don't allow them to present in a way, so it makes it very difficult to have a flow of thought. In which case, it is very difficult.
Okay, cool. Thank you.
Okay.
Hi.
Do you have any questions? Sorry.
Shall we go to the next one?
Yeah.
Yeah, let's start.
Shall I start?
Yeah.
So this paper which I have today is the topic is about diagnostic imaging versus observation in equivocal, like intermediate risk appendicitis, and it's a randomized control trial, which is open label.
What's an open label trial?
It's nobody is blinded. Everybody knows what's been happening, starting from observation.
Yeah.
And the who are doing the procedures. Yeah. And this is published in BJS 2020, and this was published from Helsinki University Hospital. First author is to Kersey, and it's a single center trial regarding the aim of the study was
Yeah. Can you just give a brief comment on the results of the study? What do you think about the results?
it did compare with the observation according to adult appendicitis score, and compared with the early investigation with ultrasound plus minus CT for adult patients over 18, and they found that the observation group, a lot of patients, the significant proportion of patients got better with the scoring, and they didn't need any further investigations or operation. The primary aim was to basically find out whether patients acute appendicitis treatment they needed acute treatment for acute appendicitis within 30 days or not. And the secondary aim was to whether these patients presented with complicated appendicitis, and whether they needed further investigations or appendicectomy within 30 days and up to a year.
Okay. So coming from so what do you think about this study? What is your general impression on this study?
It's a reasonably good study. Having said that, they did exclude patients having pain more than 24 hours, and for it's too early symptoms, and also they did rely on CRP quite a lot, looked like, and they did acknowledge at the end the power of the study was less.
So the secondary outcomes were quite, the difference was not seen in secondary outcomes, which they explained it by lack of power in the study, isn't it?
Yeah, yeah. And also what we found is that surprisingly, the significant proportion of patients who either needed investigation or appendicectomy over 30 days or up to a year. So that's putting the main concept of the study slightly in a difficult position.
Okay. Can you just give a brief run us through the methodology and the outcomes of the study?
They included the adult patient over 18 years of age, and presented in emergency department, and they excluded the patient who has more than 24 hours of pain and CRP below 100 milligram per liter. They included the patients who are in the intermediate risk group, scoring 11 to 15, adult acute appendicitis scoring group. Also, they also excluded the patients who had antibiotics and who didn't give the consent. That's been cleared up. And they randomized computer-based block randomization with the block sizes 4 to 8. And they in the group of observation group, where they did the scoring and then repeated the scoring in 4 to 6 hours time, and they carried on with the observations till the patients got better, or if the patient deteriorated, then they needed further imaging and operation. and then they compared the outcome and also they compared the outcome during the hospital stay, and also they telephoned the patient 30 days to find out about what else they didn't need, whether any further consultation in any or doctor or needed any further imaging, things like that. I think they also repeated in 1 year's time.
So what did they? So the second time, what did they do? If the symptom score was still in the intermediate group, they still went for investigations. Was it? What did they do actually?
Okay. They did mention if few patients, if the patient deteriorated, the score, if they're getting better, then they discharge the patient.
Yeah, if the score was the same. What I'm asking is the second time, if the score was the same. Even if the score was stationary, what did they do actually?
Unchanged between 15 imaging ultrasound. So if it is unchanged, or if it is getting worse, then they requested followed by CT when needed.
Yeah. All right. Okay. What do you think about this paper?
As I was mentioning that this is reasonably well done randomized control, but having said that, because of the follow-up was quite, the inclusion was restricted within 24 hours, too much of reliance on the CRP. And I actually, when I went through the tables, then found all the patients were below 40 years, which was slightly odd to me. So the mean age was 30 years, and possibly they didn't include over 40 years. And and in the age group around 40 years, there is a good point of getting a CT scan done to exclude other pathology. So they didn't take that into consideration. And as I was mentioning, that 30-day follow-up and 1 year follow-up, there's a significant proportion of patients needed either imaging, and there's a significant proportion needed appendectomy as well.
What are the limitations in the study that you think are significant in this study?
One of the things I would say, they didn't include patients more than 40 years. They didn't include patients more than 24 hours of pain. And I'm not very sure about this adult acute appendicitis score. I'm not sure whether it's a validated score or not. They relied on that.
They said it is validated. What about other limitations, like they've said about recruitment was at times very slow, isn't it? That was one of their main factors that they said.
Mentioned that.
And there was a large amount of hospital crowding and things like that. And there was also a lack of power, isn't it? That was one of the main
lack of power,
in the
yeah.
study.
Lack of power.
Yeah. So can you explain to us, coming to the outcomes, can you explain the outcomes to us now? The primary and the secondary outcomes?
In the primary outcome was, they put it like patients, the number of patients requiring treatment for acute appendicitis during 30 days after randomization. I think they achieved that reasonably along according to their hypothesis, which mentioned that a lot of appendicitis can resolve without any intervention. But having said that, I was not sure whether the patients they are saying that had appendicitis but there was no proof of them having appendicitis, whether it could be something else, because there's a small group of people in the observation group who didn't have any investigation, they got better. So there was definitely evidence that they had appendicitis. The secondary outcomes were they mentioned about complicated appendicitis, which needed operation within 30 days. And also they follow up whether people needed investigations or any operations in 30 days and 1 year. They achieved that, but as I was saying, that there's a 72%. When you look at the table, 72% of the patients needed. There's a cumulative number of appendicitis within a year in the imaging group, and also 60% patients needed appendicectomy in the observation group. So that puts me in question whether we are missing some appendicitis, which got better for it, but had a flare up within 30 days as well.
Yeah, and that's a good point actually. With that, they didn't use only surgery as they used only surgery as a form of treatment, whereas they didn't use others like antibiotics and things like that. But they have considered a very small group of mild acute appendicitis, where they didn't want these people to be influenced by antibiotics because it would subside, isn't it, and confound the diagnosis.
Mm-hmm.
So that though it is possible to take that as a critique, their main focus was only in taking mild acute appendicitis and then seeing their progression. But if you give antibiotics, you may not see their progression. So that could be the rationale in saying is to not to have antibiotics in the first place. Mm-hmm. However, it is when you compare it in a generalized way, yes, they didn't give antibiotics as a treatment arm, which could be used as a critique, but they were looking to compare only these two. So in a narrow sense, yes, that they should have, you could have given another arm for antibiotics, but in this they have selected only these two. So their rationale was okay, if you ask me. Anyone has different thoughts on this? Sindel?
I'm still working on the fact that they're comparing. See, mild acute appendicitis also management is surgery, right? Irrespective of whether we have diagnostic imaging or not, if your score is intermediate, you have clinical features. So I'm still trying to grip the fact that they're going for observation in those patients, and then what? As in, if diagnosis mild.
I think their rationale was that mild appendicitis resolves, so there is no need for anything to be done. So 50% or something resolves.
It resolves, and then what? We just leave it alone. We're treating it as, say, diverticulitis.
We just something like that. So their rationale is that it just subsides, and that doesn't come.
Whether it's appendicitis or not, and you're doing observation and it goes away, and it's not, it's fine. But then if they're saying that they're comparing a management strategy of observation for mild appendicitis when the standard of care is still appendicectomy, I'm a little critical of this paper.
Yeah, because 60% of these people needed appendicectomy within a year at least. So that's the thing they didn't highlight it in the discussion.
That's what. So
yeah,
I think that's the.
So if you are an editor, would you publish this paper from the what they've given?
There's a question from Vivek. Amar, do you want to answer? Because I didn't listen to the whole of the conversation and I was just doing something else. Vivek has asked some question. Will it be possible critique of the paper to use only surgery as the form of treatment in the paper? I think to get a real idea of the paper, one needs to have a background of the AAS score and the group experience with the same.
I have no experience with the AAS score, but I understand that it is used for adults more than 18 years, and they divided it into three. So I don't know if anybody has experience with this score.
No, not with using it as such, but it's similar to your Mansell Alvarado
Better
rating.
than
They
other
give
scores.
all the factors, pain, tenderness, and the scoring is much higher. More than 16 is high risk for appendicitis.
16 is high risk, isn't it? So it's just 11 to 15 is
Yeah,
intermediate
so
risk,
they've
which
taken
is
the intermediate category.
investigation. What do you think of this? Sorry,
Amar, audio is a bit
someone was saying something.
intermittent.
Yeah, it's
Okay,
breaking
Can
up.
you
sorry.
repeat the
Please
question,
repeat the
please?
question.
So I didn't say something. I said somebody wanted to say something.
Okay.
So what did you think about this paper? And what are the other critiques on this paper? Would you publish it if you are the editor, Sanjay?
The good thing about the paper is it's something we need to think about, because especially in recent time we've been investigating all the appendicitis with the CT scans. So this is putting us in a perspective that whether we should follow up some of these patients with observations if the suspicion is low. So that's definitely one good point of inviting this paper. And if I were in the editorial, then that would be a good thing for me to choose this paper to publish. Actually.
Are you happy with the number of patients that they've included in the study? Do you think it's a what do you think about
It's a
that?
single center study. I think between 2016 and 20 they did. So 93 in each arm, they put it like 93, 92 in each arm. So it's not powered considering the incidences of appendicitis and the intervention. So I think it's not, we need a more number.
Sorry, Hani Rasada said if I plan for appendicectomy, I could use antibiotic. If not, no. Oh, so as a rationale for that, yeah, that's correct. As to why they didn't use antibiotic.
Yeah. My opinion would be that I think I would be highly reserved in publishing this paper, considering this is acute appendicitis in today's day and age, to have an open-label, single-center randomized trial, and to determine between observation versus surgery for mild appendicitis. In fact, the score is, they've taken patients for intermediate score, and they've called it mild appendicitis.
They made the correlation between intermediate and mild. They made the correlation between intermediate and mild. That's what you're saying, isn't it? They made it a correlation between intermediate. They assume all patients will appendicitis.
Yeah, they've assumed all patients with appendicitis. Intermediate score, CRP of less than 100, and the fact that the power of the study is less, single center study. I think it should be. I would be very reserved in publishing this. Hopefully, if one of the examiners is not one on the author list.
On the list.
No, you are right, possibly in a sense, because the main hypothesis for this study, they mentioned that they say that the appendicitis some of the early appendicitis do get better on its own, which is not very sort of scientifically right either. And also they haven't proven that these people who got better, they had appendicitis.
Definitely. So that's answering the questions whether mild appendicitis needs surgery or not. As in the study, they have said that it resolves on its own, and they've given a percentage of like 40 to 50%. isn't it? That resolves on its own, which I was quite surprised. But how did they first diagnose it in the first place? That's also a question that needs to be answered.
Exactly.
And they, if they give you such a long study, I would instead of reading it fully, I would suggest just go, because there is no way that you can finish it in that amount of time, read everything through. So just concentrate on the salient features and try to read more from the discussion. And because sometimes reading the methodology, you wouldn't have much of time. So read the discussion and then you can come to methodology and outcomes. So before in the exams, sometimes you don't have time. This is especially for papers like this, which are very long, very winded, where you don't really understand, this. The examiners get this paper well in advance. But I wanted to do it like just before you guys, so that we all do it together. But the examiners actually get the paper like a few weeks in advance, so they kind of read it up. So I would suggest in very long-minded papers, instead of getting into the basic, nitty-gritty of things, get into the overall scheme of things. That would be better rather than getting into the nitty-gritty, which would help you, overall.
Yeah.
Just wanted to ask you something. Can you give us a list of can you ask us the list of commonly asked questions in terms of academic vivas, like what is sensitivity, specificity? These are the easiest things.
There's a good checklist, viva academic paper, viva checklist on that surgical education. So the Alpine course site.
Yeah, I had a look at it, Sandil. I'm saying there'll be few questions like what is impact factor, what is Kaplan-Meier curve, what is like there are a few repeated questions like what is intention to treat analysis, what is number needed,
p-value. These are the most common things that they ask. P-value, things like that. What is a p-value? What is p-value? What do you think about the p-value here? But so these are the questions that they routinely ask. But most examiners do not ask about statistics. This is something that I've seen, that they don't ask too much about statistics. But of course, there are always exceptions. But most examiners don't ask mostly about statistics. They're more into the the surgical aspect of it. So the methodology and the surgical aspect of it, into especially the limitations, how does it affect your practice and things like that. Very practical questions. Most of the examiners. However, that being said, there are some who still continue to ask these questions. However, these are very basic questions, so I'm not asking all those. But sometimes they start with what is an impact factor and things like that.
So, for example, in my paper, there is a logistic regression analysis. What is this? There was another like per protocol analysis. Will they ask such questions like where we don't come across what exactly is that at all?
See, there are two ways to handle that. One, if you know it is well and good. If you mostly examiners go from what you ask. They very rarely they go from what you do. If you do not say something, they may not ask, but sometimes they will ask. I would suggest the basics like per protocol analysis. What is per protocol analysis? A forest graph. If they give you in a meta-analysis, you should know all that. So sometimes they will just ask you, along the way, what is this? But that is not the main crux of it. The main crux of it is the discussion and things like that. The outcomes. That's what they're affected in asking, and how will it affect your practice, in the sense.
Okay. Amma, can you suggest which of the commonly used journal, BJS Open, extract for review from?
So most commonly it is BJS or BJS Open Access. Sometimes, very rarely, they may give other papers, but I would suggest go through BJS, recent BJS for at least BJS and BJS Open Access for at least the past 2 years. In case of Open Access, then they would ask questions like what is Open Access and things like that. So you immediately know that will be one question. These are questions that they will immediately ask about what is Open Access. And so you should be in a position to answer it. These are the times like it stays in the place like open label, open access. They would expect people to know what is open access and things like that. So that's the first question. It's not even so the first question will be what's open access and what's the impact factor. So this is a given to start. So that's not the end all of it. So sometimes they go asking more about what is an impact factor, what are the disadvantages of using impact factor, and things like that.
Okay.
I finally
And
got my head around. Sorry, continue.
sorry, tell me something. Sorry.
No, I think the paper, if it was diagnostic imaging or direct laparoscopy for mild appendicitis, then that would be comparing how many people in mild appendicitis either need imaging or how many people end up with a negative laparoscopy. For an ethics committee to release and say observation is the management arm for early for mild acute appendicitis
But
itself is,
which
I'm
they are
finding it
not
difficult.
sure.
Yeah.
But which they are not even sure it is mild appendicitis in the first place.
Exactly.
It's just right for pain, basically, if you ask me.
Yeah.
It is basically right iliac fossa pain. It is appendicitis, could be mild, 9% will resolve, very few will require surgery. So that's the basic premise in which they're working, which can be wrong.
Yeah.
Which is wrong, actually. So anybody has any questions, you can just type it on the group or anything, any comments or anything that you can ask. So this is basically, they ask questions like either they allow you to present, which is the most common scenario, or the second is they just ask questions from the beginning, especially when they have the same paper and the same candidates keep going. In the afternoons and in the evenings, they get tired. So at that point of time, it's just the straight questions. They will start with what are the benefits, what do you think about the trial? Can you tell me about the good points in the study, the bad points in the study, and things like that. So I suggest you be prepared for both. The good case scenario is the first scenario where you are allowed to present a paper and you can, explain your way. Most likely afternoons or evenings, they imagine the examiner, he's asking the same questions to the same group of candidates or the same paper. So he gets tired. After some point, he starts asking questions like when you go in, he asks what do you think are the good points of the paper. So what I suggest is mark out all the good points, mark out all the limitations and the bad points in separate colorings. They give you lots of colors actually in the exams. So you can take green. This is what I use, a color coding scheme, like green for good points, red for bad points, and brown for or other colors for all the mundane ones, so that it's easy in that case. Otherwise you'll be like searching on the paper and so be prepared for both forms of view. We haven't discussed the second paper in much detail, but this is just to show the gist of how they ask questions.
Okay.
I mean, we haven't really gone into
one question I have is how
details of
do
the
we
second paper, like the first paper where we went by table after table after table. Sorry,
sorry,
I
my
didn't
question
get your
was
question.
how do you assess references? I mean, one glance, okay, if it's obviously two less, but is there a number you'd say, two less, okay, 10 would be too less for me, or 15 for an RCT? Like this one has 29, and then I'd briefly glance at the dates and make sure they're kind of recent, but more than that, I don't think I will have time to assess the references.
You in reality, you will not be in a position to assess any references or anything, isn't it? So you mean like saying that, so I would, not make much of a comment on references anyway.
Fine.
Unless it is a reference in which you are, say, disagreeing completely, or in that case, maybe the reference is important. Okay. Like when they've quoted something and you totally disagree with what they've quoted, in that case, you can quote this reference and say that this is something that I don't agree. But overall, I don't think you should waste because it doesn't really help your cause. They mainly look at the methodology and the outcomes, basically, and the discussion aspect of it. Even the statistical aspect doesn't account for much.
Okay, so I'll rather leave them to ask. If they ask those questions, then I would say 29 is probably less for a randomized control trial. But otherwise, I won't comment on it and get into trouble.
Yes, but because then they would ask you, what do you think is the ideal number and things
exactly.
like that.
That's what I was asking. Yeah.
So it was not.
I think if I'm not wrong, minimum 7 to 10, isn't it? For any paper minimum 7 to 10.
I think less than that, there's no, they won't publish anything less than that.
Yeah.
But it is all based on papers, isn't it? Certain journals, you can publish any, the upper limit is The lower limit is like 7, I believe. The upper limit is like anywhere. Some journals accept any number of references. Some have like 15,
Yeah,
20 at
some
least.
are like
15,
40
20.
also.
They have a limit, isn't it? So
Yeah.
Just one more question.
Uh,
How good we need to be looking at the tables rather than the paper, the discussion and paper, the printed bits. So do we need to be quite critical about the tables and figures?
I don't think you need to be very critical if it's non-statistically significant. The ones that are statistically, so when you go through the paper, just go through the tables which are statistically significant and mark them up. Even that I would not really say unless they, go through it. Because what you have very little time in the exam. It's like about 15. It's about 15 minutes. It's very little time. So they have to cover the entire paper. So they are looking for a general overall idea of you about the paper rather than into the nitty-gritties of each and everything. Go through. It's not the case.
Thank you.
Amar, regarding the timings, I'm much more worried about the timings. How far the 30 minutes will be sufficient to read the whole
You
paper
wouldn't. You
and
wouldn't.
assimilate things and get an overall idea
You.
and all the salient
So
points?
it's very difficult. I'm telling you, you can't. There is no point in trying to ascertain everything within 30 minutes because you can't. Nobody can do it in 30 minutes. That has to be a human limitation, which all of us understand. The question is, what are we concentrating on in those 30 minutes? Because examiners know, because they have the paper well in advance, they can go through it. But everybody within 30 minutes can't go through the entire paper. So and they are not expecting you to go through the entire paper in great detail. So first, you should have an idea of the paper. What first, if I would ask me, I would just suggest you to go through and give a glance of the entire paper. Give a glance of the entire paper in the sense, just read about the abstract and the conclusions, see if it makes sense. Then you go to the discussion, see if it makes sense, and then go through the other things. Because the question is, nobody goes through the tables because if you start going through the tables, because most people are waste a lot of time on the tables and things like that. If you can go through them fast, that's fine, but most of them have difficulty going through each and everything, all the tables, and going in an order. So if you go in an order, sometimes the time's all up for some people. Some people, you wouldn't even finish reading the discussion in the full discussion. So I suggest giving a very fast skim of the discussion first, because the discussion is basically the rationale and everything that they're trying to explain in the paper. This will hold true for any paper. Discussion, I would rather suggest with the reading the abstract introduction and then have a look at the discussion, adjust and understand what they really mean, what are the limitations, because it is much faster to comprehend. This is what I personally feel, but there are many ways of doing things, as in there are many ways to skin a cat. So there are many ways to do these things. But if you ask me, it is better to give a very fast glimpse first, get a general idea, and then go reading, through the paper in detail, a bit of detail. But this is all provided you have time, which I presume you wouldn't. So whenever you read, I would suggest just mark the important things only, so that you can, and they give these colors precisely to help you with that.
Regarding, like, for example, if the examiners are more concerned, more concentrating on the methods and the methodology, with the abstract, with the short abstract, in my paper, there was no complete explanation of the methodology. If they ask for the randomization, what kind of randomization, how these things has been done properly. So will it be will it be good to read the methodology and all these things, or just the abstract and discussion?
No, I'm not saying, just saying first read the abstract discussion, then go in detail with the methodology. So go in an order so that you get more idea. So that whenever your time is up, you have, you are able to
Something in
read and
my, okay.
assimilate faster. Because
Okay.
what happens is that if you read it in an order, it takes sometimes lots of time. If you can read it, that is fine. But usually go through a very fast skim, and then you can, the entire gist of the paper, then you can go through it in much more detail. That's what I feel. But of course, there are many ways to do things. This is what I feel, and I think this works out for me. So I don't know about others.
Yeah. Yeah, Varun, they've mentioned that methodology is one of the most important things, and you will get most of the questions from methodology. So it makes sense to say skim through the introduction, don't read it even if you need to. First read the methodology after abstract and concentrate on that and mark the important points. Again, it's like a checklist. So is it randomized? If it's randomized, is it double blinded? All those things, or is it a controlled observation study, etc. But I think I would read the methodology in detail, because the abstract is anyway, it cannot be more than 200 or 250 words, rarely 300.
Yeah.
So they're never going to give you enough information. But I would look at the conclusion key in the abstract.
The abstract is just to get the idea.
Yeah, just a rough idea.
Is just to get a look at the idea first, read the idea, and then read through. I would suggest. But
Yeah,
I would say you
method
the
would
more
be-
important things and they concentrate on.
Yeah, I would go to method in detail, and I would go straight to discussion, because the discussion should include their background study, comparison to other study, their critique of their own study. Ideally, these things should be there. And if they're not there, you can mention it as points that these are limitations of the study. And if they're there, then it gives you an added advantage to they're critiquing their own study. So you'll get the points like the power or the sample size, or whatever it is. If they need more studies, if that's the conclusion, then you've already got negative points from the paper.
Regarding the statistical questions, like will they ask anything about what are the variables used? What are the continuous variables? What are the categorical variables? Have they used the appropriate statistical tests?
They usually don't ask these, because if it's from a BJS, usually the appropriate tests are used. It's usually the case. So they don't usually ask these questions, but of course, some examiners may be more interested in statistical analysis, but usually they don't give much importance to statistical analysis, is what I've seen, contrary to what is really I was expecting, not much. In methodology, they stick on to a lot, and methodology and these things. But statistical analysis, we do very, very detailed to that. Maximum they ask you, what do you think about the appropriacy of the test? What's a null? What's a p-value and things like that.
All right, Amar.
That's very helpful.
Sorry.
Thanks.
That was very helpful.
If you have any questions, we haven't gone really into the statistics and things like that in these papers. This is just to give a rough primer as to how they ask, not really to go into a particular paper, because you might think that they go into detail in every paper, but they don't, because there is very little time. So within that time, it is how you make an impression, and you have to give an impression that you have covered everything and things like that. So that is more important. Is that what they look for? Whether you have an overall sense of the picture of getting caught. Sorry.
This is a 15-minute off a 30-minute session, right? In one of the clinical blocks, the clinical viva.
Yeah. The other 15 minutes they ask you other questions. So it is like applied surgery and things like that, isn't it? Pathology, applied pathology and things like that. So it's a 30-minute block, but 15 minutes is only for the academic paper, and only 15, and another 15 minutes is for applied pathology.
Okay. When you go for these blocks,
the pathology,
Sorry. When you go for these blocks, the 30 minutes, would you know that this is going to be a specialty block? This is going to be general surgery?
You before the exam, they send you a paper they email you saying you have to go to this table at this time for this paper. Like academic for you is between 15:30 to 30:30. So sorry. 3 o'clock to 3:30 is your session. Then they say your major session is this, from this time to that time. So you know very well that this is going to be a long case, this is going to be a short case. But the point is, in long cases, sometimes you wouldn't be comfortable with the cases. That's the only thing. You wouldn't think that this will be a long case for you. Like sometimes pancreatitis can be a short case, long case, it can come in viva, it can come in anything. So I would suggest not to, Yeah, splenectomy is a common question. Like I got it, I did both my FRCS, like international before and this the JCIE. So
Yeah.
I feel that they ask splenectomy is asked in every exam. So there are very few questions that they tend to choose and they ask, like splenectomies and things like that.
Okay.
Splenectomy, pancreatitis, these
Hmm.
topics are very common and they tend to ask more of these. So you should be
Yeah, in
really,
that I think the
they ask
curriculum
lots
thing
of
in
these
FTP
questions.
at least some 30 topics are there, and hopefully it comes from that. So not long cases.
But in general, you see, they can ask anything. In general, they can ask
Yeah,
anything.
yeah,
They
of course.
Can I
cannot
ask?
really say in the gist of answering everything. The mind of answering anything that they ask rather than, does anybody have any questions or anything about
Yeah,
the exam?
if they ask just to give a summary of the paper, then basically
Yeah.
it's abstract, isn't it? Some abstract is the
Yes, plus a little bit of, so what, that's what I was suggesting is just give the abstract first, then go and explain the methodology. So if you give the abstract, what they expect is the basic introduction with the results and then go into the methodology, because methodology is the crux and where you can go off target. Because what happens is methodology, you can go here and there and then you don't go to the outcomes, because that can really if you're thorough with the outcomes, you can just say that this is a study that they did for this and this, compared this and this is what they found, and then go to the methodology in detail. So that's where the crux of the matter is, and that's where the money is, so as to speak.
Okay, thank you.
Cool.
Thanks, Amar.
So I wish you all the best for the exam,
Thank
though we
you.
haven't covered it in very great detail though in this paper.
No, I think it's given us a good overview of
So
what we
yeah,
need to work on.
I didn't want to really go through the read sorry.
No, I think someone in the background.
No, sorry, I
It's
didn't want
fine.
to go into it and make it a really, go into the methodology and things like that. But because there in the exam, there is very little time. If you ask, I want it to be as like an exam where it is like 1 hour
Yeah.
before you get the paper and you present it. So this is how it's going to be in the exam, where you wouldn't have much time to go into everything in detail.
Cool. No, that's
I
good.
actually
Anyway,
felt the same thing, Amar. Like when I was reading the paper, like around 20 minutes, I was off the paper down, and then I just skimmed the rest of the things, like all the tables
You
and all these
wouldn't.
things.
You wouldn't really that's what's going to happen in the exam. Every exam you wouldn't be really in a position to read everything. So I would suggest you make it a habit when you practice a paper not to read fully, because you can never do it in the real exam. And plus there is a tension of the exam. You will be like, suppose you have the academic paper at the last, you'll be tired, and there are lots of other factors that play a role. So I would suggest, it's definitely you will not be in a position to read everything like how you would like to.
Yeah.
yeah, I don't think I'll be able to finish reading the paper in 30 minutes. This one I started exactly on time and just literally did that. And I was like, thankful I'm not answering the question.
No, because and I read the paper with you. I didn't want to read it beforehand, like long time before, because then you will have more questions to ask, which is not fair. Also, isn't it? So
It was
you,
good.
but that's how it really they ask.
We just
But
have to manage the time like we do in any exam. That's all.
and it is not that difficult. If they allow you to speak first, just say very calmly, go
Yeah.
slowly, say more about the paper, about who the authors are, and things like that, so that
Yeah, just get through.
you get into a rhythm. You have to get into a rhythm before you want to answer.
Yeah. Cool.
Overall, what is Amar's opinion about the two candidates?
It was good, but the thing is, just be more, just practice more and more about these papers. Practice these papers, because at one point of time you become so tired in the exam where you question. Sometimes you may just have to, go with the flow of things. So keep practicing. and you must have you must be ready for certain questions like limitations, things like that. So keep them ready in mind so that you are ready with that, and try to lead the examiner rather than the other way. So once the examiner, but of course there are different examiners, types of examiners. Some allow you to take it with your own way. I would suggest practice more and more, because it's very easy to ask more and more difficult questions. But you have to practice. Sorry, there's someone reading the comment. So you can practice more and more. That gives you an idea as to how to
definitely.
answer. It's basically a question of more and more practice. I would suggest keep practicing with you. Like, it doesn't necessarily need to be your specialty. These are very basic papers like incisional hernia and appendicitis, whereas in your real exam you would have something more closer to your specialty. But if they give something like this, you just can't tell them that this is not my specialty. Like, if you're a upper GI, this is not mine. You just can't say this is not your cup.
Do we need to? Sorry. Yeah, correct.
Sorry, sir. Continue. Sorry, Sanjay.
Yeah, do we need to know the impact factor of the common journals?
It is always better if you can provide them with a figure. It is always better, you see, when a candidate comes up with a figure, it is always better for the examiner. I would suggest just knowing BJS and BJ Open is enough, and knowing which journal has the highest impact factor. That may be
If I'm not wrong, Lancet
another
has got the
deep
highest
question.
impact factor, isn't it?
Yeah, I think it was Lancet before the COVID thing that they did. Anyway.
Yeah, BJ also, like Varun, you said high impact factor, but you can say for surgical journals, it's got a high impact factor. Otherwise, there are
Okay.
you have the other stuff. So you have a lot of medical journals that have a very high impact factor.
I presume, especially for Lancet and things like that, because they're discipline dependent. As in surgery, you have lots of journals, so they may not be cited as well. For some rare diseases journals, they will have very, very high impact factor because they don't have much discipline, publications in elsewhere. So they have to all have to be cited from this one only. So it makes no thing.
And I think the other standard things are to just have an idea about that levels of evidence of the papers. Like, this is RCT, it's level 1A. If it is
asked whether it is, you don't need to know the exact Oxford or the US PTF or the various scoring systems. Just say meta-analysis first, systemic reviews. They ask what's a meta-analysis, the difference between a meta-analysis and systemic review. That's a common thing if you get it. And if you have a forest plot, they may ask you, the diamond, and what's the diamond, what's a confidence interval, what if it is small, what if it is large. So if you're going for, say, a meta-analysis, concentrate on the forest plots where they ask you about the diamond, what is the size of the width of the confidence interval. This is all given in your cracking your FRCS, so I'm not really going into it, but this is what they ask. So especially if you get meta-analysis, concentrate on the forest plots, which is easier to ask questions to you from those. If anybody has any questions, can you just write it in the group? Any opinions on how it was, whether
regarding can everyone
lacking, missing this?
I'm going to Amar, are you happy to give your email ID so that we can ask them to send the comments, how to improve, how to
sure,
make ourselves feedback, please. Everyone can email us. Sandil, do you want to put your email as well?
Mine?
In the chat box.
Yeah.
Can you
put mine?
Give us an email? Send us an email with the.
You want me to put my email?
It's okay. Yeah.
No, my one is enough, isn't it? If one person puts, that's fine. Mine is fine. That's all right. One is enough if they.
That's a nice short email ID.
Sorry?
That's a rare, nice short email ID, I said.
My real email ID is very rare, very large. I can give you that, but it's large that.
Honestly, this is a good idea.